Good afternoon, everyone. Thank you. Thank you for joining us today. My name is Hilary Heichman. I'm a Deputy Director at the Robert Wood Johnson Foundation. The mission of RWJF is to improve the health and well-being of everyone in America. For us, that means we're working to dismantle just centuries of structural racism in healthcare and public health and in communities across the country. So this work, as I think we all know, it is not easy, and we know it's not going to happen overnight, but we must charge forth. So the intersection is a gathering place for those who are working to improve equity for everyone in the United States. It's a place where leaders in community advocacy and healthcare can share information and resources and inspiration. So the intersection, it's for you, it's for all of us. It is a place, it's for all of us. And whether you are here, you're here from a position of coming from advocacy, an advocacy organization, or if you're coming from more of a healthcare organization, a healthcare institution, it really is a place where we can all come together. And we know that this community, it's comprised of people working in different capacities at different levels with different kinds of resources, but all of us are here to help propel equity. The role of the health equity officer, it looks really different across organizations. Unlike the role, for example, of a chief medical officer, there's not really a consistent model or like a typical job description. It's complex and it's an important position. It requires deep understanding of internal initiatives and workflows, of community dynamics and needs, and systemic inequities affecting staff and outcomes and the community as a whole. So today we'll discuss how healthcare organizations can set up their equity leaders to thrive, and what community members want and need from equity officers. Success starts with internal and external support, which is why we're convening this conversation about how healthcare institutions and advocacy organizations can empower those who fill them. So thank you. Thank you for being here today. Please check out the website, meetattheintersection.org, to access resources about health equity topics, including short videos with health equity leaders and a podcast that's available across all different streaming platforms. And we're excited to launch a new LinkedIn group today where you can meet others doing this work and share resources and ideas. So please see the link in the chat to follow that group. So now, for the main event, I'd like to turn it over to Anton Gunn, the Intersections moderator, to lead today's panel. Anton has worked as a community organizer, advocate, state policymaker. He's also served as a chief diversity officer for a health system. So thank you all for meeting me at the intersection today. And Anton, it's over to you.
Thank you, Hilary. I really appreciate it. Everyone, I'm Anton Gunn, and I'm excited to talk with you all today. If you work at an advocacy organization or if you work at a healthcare institution, then you're 100% in the right place. This is a safe space where people who are doing the equity work in different capacities, in different spaces, this is where we all meet. And from my previous roles as a chief diversity officer for a health system, I know how critical it is to have an equity leader that is advancing the internal and external equity efforts. It's really important. I also know how multifaceted it is. At its core, the job is essentially an organizational change agent, a change maker. Because these positions are relatively new, the job description of a health equity officer is not the same at any two institutions. Many things vary, including the budget that you have, the location, the position within the organization, and so much more. So the purpose of today's discussion is to share ideas about what works well in terms of defining the position and how to gain the community's perspective in both the position itself and on the work that needs to be done. Now, before we dive in, I got a couple of housekeeping items for everybody who's watching this amazing event. Number one, please add your questions to the chat throughout the discussion. If you have a question, post it in the chat. Here's why. Because we're going to record a podcast after today's panel based on your questions. So you will generate the content for the podcast. The questions will generate the content. I invite you to stay for the breakouts. That's the second thing I want you to know. We're going to have a breakout session after this panel, and the breakouts are an opportunity for you to have a discussion and meet with other people that are doing this work. So if you plan to stay for a breakout and you need to be in a room with an ASL interpreter, please send a private chat to event support. I'm going to repeat that. Please let us know if you plan to stay for the breakouts. And if you do, and you need to be in a room with an ASL interpreter, please send a private chat to event support, and we'll make sure that we get you in the right room in the right place. Okay, let's do this, because Run DMC has already set the table that we're about to have an amazing day. I'm joined by today's great panelists who are all working to advance anti-racism in health systems in different capacities and in different states. So I'm going to start with Amy Delaney. She's the Director of Diversity, Equity, and Inclusion at Carle Health in Champaign, Illinois. She has led work to increase racial diversity in staffing, collaborated to remove race-based clinical tools, and coordinated healthcare equality index designations for all 8 Carle Health hospitals. So we want to welcome her. The second is Christina Harris. She's a physician and is Vice President and Chief Health Equity Officer at Cedars Sinai Medical Center in Los Angeles, where she promotes health equity in clinical care, education, research, and community partnerships. And we have Rochanda Hiligh-Thomas. She's a lawyer and the Executive Director of Advocates for Justice and Education. It's a community-based advocacy organization in Washington, D.C. She helps to eliminate health disparities for Black and Latinx children with disabilities. The organization is a grantee of Robert Wood Johnson Foundation's Community Solutions for Health Equity program. So welcome, everyone. And I want to go ahead and get us started. And I'm going to start with you, Rochanda. You've worked with communities for over 2 decades, and you know many of the barriers that people face to receiving equitable care. So as healthcare organizations establish these positions for health equity officers, what do they need to prioritize to be sure that they accomplish their goals?
Thank you, Anton, for the introduction. I would say first, health equity officers need to know the needs of the community and build relationships with advocacy groups. For example, our organization serves as the Family to Family Health Information Center for DC. Every state has one, and those are family-led organizations that support families with children with disabilities and special healthcare needs, and also work with healthcare systems, legislators, and others in the healthcare ecosystem to understand the needs of children and youth with special healthcare needs. They also need to be empowered to work independently with these groups and to create change at all levels.
Fantastic. Know the needs of the community, and they need to be empowered to create change. Fantastic. I want to jump to Christina very quickly. You're trained as a primary care doctor, and for 2 years, you've worked on the administrative side. So not necessarily seeing patients, but on the administrative side as a chief equity officer. With the experience you have now, what skills do you think are most needed in your position as a chief equity officer?
Thanks for that. So I'm trained as a primary care doctor. I have spent a good amount of time on the academic side, more so in the education. So I will say being the chief health equity officer and thinking about hospital systems and how they run is quite different. I would think, a lot of the skills are transferable that you bring from even managing a practice or academic space, research, what have you. But it so heavily relies on influence. Like I've always said this, like I am one person and I have a team, but kind of a small team to do a very big job. It is not all of Christina's work. And if I'm doing my job right, then I am influencing all the people who do all of the work to do it, but with just a little bit of a different slant. I used to say when I started the job that if I'm doing my job right, I'll be out of a job in 5 years. Now I'm 2 years in. I've upped that to 10 years because it takes time. But it is really about, as you said earlier, Anton, change management and influencing, encouraging, and honestly, people want to do the work. They just don't know what it means. They don't know how to say the words. They don't know where to start. And so my job is like to give them the words, to push them, and to be the best backup dancer they can be, build their supports and infrastructure.
Fantastic. That imagery of a backup dancer.
Well, we started with Run DMC.
That's
so
right. Now, they didn't have a lot of backup dancers, but I would tell you, a lot of artists did. Big Daddy Kane, who we had at the last intro, had definitely backup dancers.
Yeah, those ladies. You got to be those ladies in the back.
That's right. That's right. Okay, so Amy, that was great. Influence, I'm going to take that in, is influence and patience and time. But Amy, you know, collaboration is a big part of this position. So you've been doing this work for several years. So give us some sense of what it takes to do the job well from your vantage point.
Yeah, thanks for that question, Anton. I think I had this image that I looked up in some old Teams files as I was thinking about this conversation. And I've seen this image in a couple different places. I don't know who exactly to attribute it to, so I'll just say it's not mine. And it says something to the extent of diversity and equity and inclusion leaders wear many hats. Which hats are you wearing at your organization? And there's 28 boxes. I won't read them all, but it includes activist, analyst, cheerleader, collaborator, defender, but also prosecutor, educator, historian. We didn't land where we are in terms of health and equity out of nowhere. There's history to policies and practices and norms that got us here. Role model, researcher, storyteller, sociologist, that's a lot of jobs. And so doing this job well actually means doing a lot of jobs very well. And I think all of us in these leadership roles have a lot of those skills, but we need to partner and collaborate and form alliances with others within and outside of our organizations to help us do that. And that sometimes means working with a social science friend who is a historian and can help me unpack the right resources to explain why race-based PFT interpretations are harmful to our patients and get back to the real root of where that came from as I educate others on those problems and solutions as well. And so something that's been really important for me as I've entered this role as a former academic and social scientist with zero clinical knowledge, expertise, or experience has been listening, has been finding those spaces where I'm connecting with those who are delivering care and forming strategy and guiding our organization, and listening and learning about the work that they do before jumping right into telling people what they should be doing. And that's hard for me as someone who likes to talk a lot and sometimes thinks I know all the right answers. It's recognizing where my background, my skill set has strengths, but also doesn't reflect the lived experiences of care delivery. So it's something we've all talked about here before, is that we can't do this alone or in silos. And sometimes the role of a health equity leader, as Christina said, is, another analogy from backup dancer is like, I set the table so that others can feel empowered to take on those equity issues themselves.
Very good. That's a great analysis. And when you were naming all of those different roles that you got to play, the advocate, the prosecutor, the defender, the listener and learner, I saw some head nods. You had an amen corner going on here from Christina and a few others. So Christina, can you just kind of share, like, if you had to think of all of those roles that Amy framed up, which is the one that you feel like you've been having to do more of, and which one you've been doing less of? You got to do them all at some point. Are you more of an advocate, or are you more of a teacher and educator? Do you feel like you're having to defend the work or prosecute the work? Give me some sense of that.
Amy, I was on this, my head was about to break by the head nod. Like, it's all of those things all at once, all at the same time. I think that the two things that kind of rang true to me as she was going through that was the listening, but knowing when, like, it takes a lot of humility to realize, like, if we are responsible for influencing equity all the places, there is not one person that can influence, that can like know everything about what equity looks like in research, in education, in clinical, in the community, and in, you know, patient acquisition. It's a lot. It is really a lot. And so you have to be humble enough to listen and learn and, you know, create what equity looks like for all of these spaces that make hospitals and clinic systems run round. But you can't just spend the whole time listening. At some point, you have to say, you know what, like, I am the equity expert here. And this is, thank you for informing me, we will co-create, but now I'm going to lead. So it is, I sometimes struggle with this, like, when am I influencing and when do I just need to be in the front and do this? And that is, I think, it makes this job very, very challenging. And I will say, I think we're going to talk a little bit about reporting later. You know, wearing all these hats, I constantly tell my bosses, like, you have to remember, like, I have to do all of these things. And I think in some respects, many hospital workers do have to wear many hats, but I think it is different. And I think the expectations are different of us. It's just the way it is.
That's a great perspective. And yeah, there's a lot we're going to unpack and talk about, but I want to ask Rochanda something else. Like, you know, you are a part of the community. And the first thing you said is that people in these roles need to know the community and have a connection with the community. I just want to ask your perspective. Do you feel like most institutions do that well? Do you hear from people in equity roles or chief leadership roles in terms of spending time with you in the community? Or has it become more of you having to be the prosecutor? And I know I'm talking to the lawyer in the group, but do you have to be the prosecutor to get them to the table so that they can understand the perspective of the challenges that your membership and the people that you serve in the community are having, for them to be able to become an advocate or a challenger on the inside of the institution? Give us some perspective about that.
Yes, thanks. I was going to say, I think there's no one size fits all, and we have a number of different health systems here in DC in particular, and some of that is direct work where our organization is directly working with different professionals within those systems here, and in others we have not. One of the things that we have done or been real intentional about is how do we make sure the community, particularly our parents, are leading the conversation about what it means to have equitable health care for them. And it's through that work that we are beginning to connect with individuals in the healthcare system so that we can uplift those voices and what they see are the solutions and the changes that they need in order to have an equitable healthcare system. We also, as an organization and different members of our team, sit as a part of a number of coalitions with other individuals from the healthcare community and are able to engage with them directly. But one of the things that I think is important for healthcare systems, or especially for someone in this role, is to be real intentional about how they engage with community, whether it's through focus groups, town halls, going to places and spaces where they are meeting community, where they are to have firsthand knowledge and understanding of the barriers, the challenges, what's necessary, what also prevents some community members from even accessing care or attempting to access care and all, because there are a number of issues that are there too. But I'm going to pause.
Very good. Well, definitely. Thank you. Amy, anything you want to add on there?
Yeah, I think especially to the last point you made, Rochanda, one of the things I think about, I want to get this to a more fully coherent thought, but we talk a lot about trust and mistrust in healthcare, particularly from minoritized and marginalized communities. And I remember when I first started in this job a few years ago, it was during COVID, and a lot of the discourse around mistrust was around vaccine, the COVID vaccine uptake. And I had a very senior leader in the organization email me and say, Amy, how do we convince our Black and Brown community members to trust us on the vaccine? And my response was probably a bit more measured than what I'm going to share today. But it was something to the effect of, the question can't be, why don't they trust us? It has to be how have we not been trustworthy? And the key to building trust is not to convince you to trust me. It's to sincerely be trustworthy and to earn that trust. And so I think what Rochanda is speaking to, and what I'm sure we'll continue touching on in the conversation, is kind of how those community connections inform kind of not what we say, but what we do and who we are as healthcare providers in our communities.
Yeah, I want to probe on that a little bit to you, Amy. That was a great response to that senior leader, but particularly for your role, do you feel like it's your responsibility to be that trusted partner with the community? Or is it your job to make sure that leader that you were talking to is the trusted member of the community? Because, you know, when I was in my role as a chief diversity officer, I felt like I had to be the lens by which the community built their relationship with the institution versus everybody else in the institution. But I'm wondering, did you have that same kind of a framework or challenge with your institution?
Yeah, I think that question goes right back to the core of the purpose of this webinar too, of this role looks different in different places and with different frameworks. So my answer to that question is B. It's more about that other leader. Here at Carle Health, we have an entire community health initiatives arm that does a lot more of that direct community facing work and trust building and delivery of healthcare than me as an individual or my team or even the teams I work closest with. But I think in other organizations, the answer is 100% A, and it's such a core part of that role that I think some organizations, you know, do better than others as well. Thanks for that probe there.
Yeah, so I'm going to pause right here, and I'm going to ask the audience a question. If you want to participate in the breakout, we want you to let us know. We're going to put a poll up on the screen, and if you plan to stay for a breakout group, then I want to make sure you get a chance to take the poll. The breakouts are going to run about 40 minutes and they will end by 2:30 Eastern time. So we just want to have a sense of the crowd and who's going to stay for the breakouts. That helps us to plan. So please, by all means, answer the poll. And the panelists, you don't need to answer it because we got something else to do after, because we're going to record a podcast on these great questions that I'm seeing are blowing up the chat. So we're getting a lot of good questions. It's going to make for a great second half act. So please let us know if you plan to stay for a breakout. You can go ahead and answer the poll, yes or no now. And of course, we will end all breakouts by 2:30 p.m. So gave everybody a chance to do that. I'm going to give you one last second to get it done. And then I'm going to move on with this great conversation. Okay, so I'm going to just be real transparent, just based upon my experience. I was in this role for 6 years as an institution. Some days I came to work, I felt like I was an extension of human resources because I'm having to deal with some things. Some days I came to work, I felt like I was a part of the quality and safety team. Other days I came to work, I was in marketing meetings about where we're going to spend dollars in the community to advertise with the Black Expo or advertise at the Pride events that were coming up in town. And then other days, I literally felt like I was a therapist for the leaders in the organization who wanted to see more in terms of equity, but just didn't know where to go. And they wanted somebody to feel their pain, help them to understand, and then sometimes even cry on their shoulders. So I wanted to ask, particularly you two, Amy and Christina, how involved should you be as an equity officer? And I don't want to leave you out of this, Rochanda. I think you could have a great perspective. So how involved should you be in all of these different departments across the organization? And what does it look like for you on a day-to-day basis?
Yes, it is. One of the things I struggle with is the feeling like I need to be at all the tables, but the realization that that is not function, that can't happen, right? Because there's only so many hours in the day. So, you know, how I think about this is like, how do I use other members of my team to be at the table to influence? How do I use the people who I report to? How I have to make sure that they know exactly what I'm doing and what my goals are. I also think a lot about what can I produce, whether it be from like a impact tool or a checklist or a framework that I can like, people can utilize to influence or make better decisions, because I can't be at all of those tables. So I think it is definitely a struggle. But, you know, I think in the beginning, I wasn't at enough of the tables. And, you know, I got myself invited. And honestly, as you continue to progress in your strategy, I'm now realizing I need to be at bigger tables too. So how do you say like, okay, I've been at these tables for so long, let me level up. And I will also give a plug to my institution quickly for also having a chief diversity and inclusion officer who predated me. She is my partner in all good things around this place. And this can be a lonely job. And she is my confidant. She is my friend. She is my collaborator. And we are able to divide and conquer. That said, there's still too many tables.
Yeah. Wow. How about you, Amy?
Yeah, I think, you know, my background is as an educator. I was a college professor for 5 years before I decided I wanted to do more applied work, get closer to healthcare. And so my philosophy of the work has always been driven by the sentiment we all know from Maya Angelou that says, when you know better, you can do better, right? So I see my job as creating opportunities and incentives and accountability so that I'm going to do everything I can to situate our leaders, our providers, our staff, everyone at every piece of our organization to know better. And then I'm going to set up frameworks so that they are accountable to doing better. And so that's one big piece of how I think about that, kind of what rooms and what tables am I in? I'm in every table or in every room at every table where I can create opportunities for people to unlearn harmful beliefs, practices, norms, and to learn what helps us meet that mission of trust and equity. And then I think the other piece of that is very similar to Christina. There's just too many tables. When I am there, I'm asking equity-focused questions. I'm there as an equity question asker and teaching by example so that others can start asking those questions too. And sometimes it's just asking why over and over and over again. But some of my proudest moments in my work are when someone has come to me and said, Amy, we were in this ELT, executive leadership team meeting, and the topic was not health equity, but this senior tip-top executive leader asked for the data, asked to see this information stratified so that we could make a more informed decision. And I think that's that role modeling and teaching people what questions to ask and how to think through that equity lens, because I can't be there in every conversation. And neither can members of my team or our co-conspirators for this work as well.
Very good. Now Rochanda, I know you heard their explanation of all of the different tables that they're at, all of the things they have to do. If you were an advisor or a strategist for a health equity officer institution, where would you like for them to spend their time that helps to advance the work that you do in the best way, being a part of the community and representing the community? What would you advise a health equity officer or health equity leader to spend most of their time?
I was thinking about their responses before you asked me that specific question, and I've raised this before, and that was a level of influence that health equity officers have, and that if they're being utilized or leaned on for the expertise they have to ensure that the systems that they are working for have as a part of their DNA health equity or strive for health equity, and they can't do that alone. And it's like, where's the influence, and how does that resonate throughout the entire system? Does that come from the CEO? Is that top down? Should the primary focus be in connection with those who are the ultimate decision makers and who have the influence and power to ensure that there is health equity? And as it relates to community members need to be partners in this work, in the design and the care, and not just box checkers and say, yes, we spoke with. I mentioned focus groups and town halls. That was just one way of hearing the lived experiences of community members, but that's not the ultimate place. And so part of that role, how do you really and meaningfully engage where they are part of the process, the policies that are being made and implemented within hospitals, that they are there and a part of that, and not just check boxes, and also too, compensating them for their time. Everyone at the hospital or in healthcare systems are getting paid to do this work, if you're leaning in and relying on community members to provide information and solutions, they should be compensated for that time.
Wow, you just hit a nerve with me on the compensation side, but I'm not going to go there right now. We can come back to that in a minute. But Amy, Christina, any reaction to what Rochanda offered up? Any thoughts that you want to add on to it?
I appreciate hearing her reflections, and it made me reflect on like all the tables, all the things. And, you know, this is a journey. I've been doing this 2 years. This 2 years won't look like the next 2 years. And, you know, I do think we do have to figure out how to collectively, as equity leaders, not get lost in the frenetic, you know, like here and there and there and there, and really be strategic about how we move this forward. Because if we're not paying attention, it's like, I want to be at that table, I want to be at that table. Like, you just feel like it's a lot. And so as Rochanda was mentioning, I was reflecting, like, what does that mean to be a bit more strategic about where I am spending my time, to make sure it is, because we can all get lost in the details. I love getting in the details. But maybe that's not the best use of my time. And I think anyone who is building a program, a health equity program, a D&I, like, these are the things that we struggle with and we go through. And we're figuring out that dance. I will say.
Yeah. So let me go ahead, Amy, feel free.
Well, I'll echo what Christina said too, because I'm only a year further along, I think, into this role than you are, Christina. So I don't have much additional foresight, but I think toward the end of last year, I was feeling that frenetic energy, just a lot of tabs open. We were trying to do everything for everyone all at once. And I talked with my team and the leaders I work most closely with. And I said, in 2024, we have to do a little bit less, but do it better. Instead of trying to offer 6 education opportunities each month, we're going to offer 3. And we're going to put our focus on getting people to show up to those 3 and figuring out how to create those education opportunities so people act on what they learn. And we're going to work on this accountability structure. And we're going to, exactly as you said, get more strategic so that we can be sustainable as well, because that frenetic energy will burn all of us out in the work as well.
Very good. So I want to talk about reporting relationships, because I think this is really important for people, again, knowing that the roles are not all created equal, not the same, depending on the organization. I really want to know, who do each of you report to, Christina and Amy? Who do you report to, and who reports to you? So I just want to hear a little bit about that, and then I'll share a little bit of my experience and my perspective. So I'll start with you, Amy.
So I have kind of a dual reporting relationship. My direct report is to the EVP and Chief Human Resources Officer. She has in her purview oversight over diversity, equity, and inclusion, patient experience, human resources, and marketing and communication. So that touches several of those spaces where we connect and do work. And then I have a dotted line of accountability to the Vice President of Quality, who is also, of course, highly accountable to our health equity strategy and outcomes on the clinical side. Not a formal reporting relationship, but I meet at least quarterly with our CEO of the system. That's a standing one-on-one that we have that often gets follow-up conversations going as well. And so to the kind of what this model looks like, I can only speak to my experience in one organization with one set of these relationships that have been the same people the whole time. So I think that's important context.
Yeah. Yeah. And how big is your team? So give me some sense of who.
I have 1 to 2 direct reports on my team. I had 1, and then I had 2, and one of them is moving into a human resources role. So he's now kind of a half-time report. It's not exactly a dual role. That's complicated. But 1 to 2.
Fantastic.
From my experience in this framework, The reporting relationship is much more about the individual than the title. We have at Carle Health a highly engaged and committed CEO. I came into the DEI leadership role as someone with a bit of skepticism about organizational DEI efforts. And it was in my interview with him where I gained some confidence that the commitment was real from the very top. He reaches out regularly. He speaks the language of DEI to every audience that he has. He creates space for equity discussions at Board of Trustees, ELT, other high power meetings. And so from that reporting relationship, I think his engagement and the sphere of influence of the people I report to directly, it's a good fit for what we have and where we are.
Fantastic.
Knowing that's not for everyone.
Yeah, totally. That's a great perspective. How about you, Christina?
I'll just start with Amy's comments about the CEO. I will say, like, during my interview process, it was not until after I met the CEO that I was like, oh, maybe I will do this job if I get it, because it makes such a huge difference to have someone who really does champion this. So I have two reports. I report to the CMO. The CMO also has our chief efficiency and value person, quality, patient safety. So it was a nice marriage there to kind of integrate right into the quality infrastructure and such. And then the other report is to the Chief Advancement Officer, who has community and development under him. That is because some of my jobs, even though I do not run all the community stuff, my job is to influence some of that. And I think it has worked well. It is interesting, though, if you think about the scope of the job. Like, we are an independent academic institution, so we have the academic side, and I need to work with, the dean types on the academic side and the GME, but neither of my direct reports have that under their purview. So it's like I have my life that is revolving under my two people that I report to, and then I have like a separate sort of life, or that I'm just kind of navigating out there, some of those structures. So it makes it a bit more challenging.
Yeah, that's very good perspective. And again, I served in this role as the Chief Diversity Officer for 6 years. I was the very first person in the history of the institution to have chief and diversity and inclusion as a part of their title. So there was really no precursor for me to look at. The beautiful thing about the role that I was in is that I started with a direct reporting relationship to the CEO. I wasn't embedded in human capital. I wasn't embedded in anywhere else, which gave me that line of sight to the CEO to really see what you both said you saw is, do you have the commitment to this work? Because if you don't have a CEO who's committed to this work, I don't think it matters where you sit in the organization. You'd be hard pressed to make significant strides without leadership from the top being fully invested. But I did find myself in a lot of other spaces and working in partnership with a lot of other people. So we know the reporting relationships can be different. They can be in all kinds of matrix. So I'm going to ask you this hypothetical question. If you were advising a CEO who's just getting started today and says, listen, I want a health equity officer position in my organization, okay? And they're trying to determine, what's important or what they should think about as they design this position. If you were giving advice, what's one piece of advice you would tell them to think about as they're designing this position? And I'm going to start with you, Amy.
Thanks. It's kind of a truism in this work that there's no such thing as quality healthcare that isn't equitable. Like, that's a very common sentiment, I guess, and true, of course. And so my advice to that CEO would be that whatever metrics you're using in your organization to assess the quality and value of your healthcare, you have to look at them in stratified ways. Does not matter if your safety and outcome numbers are really good, if they are not really good for some groups. And the extension of that advice is that whoever your health equity leader is, whether they're in the room or not, that focus on equity has to be tied to mission, vision, values, how we measure success of this organization. So the role of that leader then can be to help understand why those gaps exist and the path toward closing them and leveraging those collaborative relationships internally and externally But really, whatever you write in that job description or whatever expert you hire to do the job, they cannot be the only one asking for the data or talking about the priority.
Wow, that's fantastic. Rochanda, how about you? What would you offer as a piece of advice to a CEO who's creating this position inside the institution to advance equity across the board? Any advice that you would give them as they structure the role?
Ensure that they have a level of influence and decision-making power to get the work done, whatever the goals and objectives are, and that a part of that role will be, along the lines of assessing, what is the lay of the land and having an understanding of that. And as Amy said, not being the only person asking for that data, but also being in a position to be able to convene stakeholders, including patients and other community members, in discussions about what the goals and objectives are, going back to what I said before about ensuring that community members are partnered in the work and they're not off to the side as a checkbox.
Yeah, that's great. Influence, I heard you loud and clear, influence and decision making. Without the ability to decide things or to change things, you just sometimes can spin your wheels. But the key there is being in an influential role. So Christina, how about you? One piece of advice for the brand new CEO who's creating a health equity officer role. What would you tell them to do?
I would say if he or she is interested in putting equity in all the places where equity needs to be, then they might want to consider having a reporting structure that goes to the probably one person at the institution who knows of all the moving pieces at all of the places. And that would be reporting to the CEO. If that is not the situation, or that's not the legacy, or that can't be for whatever reason, then the CEO has to be very, very intentional about putting all their people on notice that this is just not Christina's work or Amy's work. It is the work of the institution. And when she asks, you listen, right?
Yeah.
So I think that's really what it takes, I think.
Yeah. Well, let me go ahead and say it the way that I feel it. I've had a lot of opportunities come to me over the last, I've been independently as an advisor on my own for the last 4 years. And I get a call literally once or twice a month from a search firm asking me to consider going into a health equity role, chief health equity role, or chief diversity role. And I always just look at the descriptions just to look at them to see where they are.
Yep.
And the first thing that if I don't see that it reports to the CEO, I just delete it from my inbox, because it goes back to where Rochanda says, if you're not in a position to influence and make decisions, then it's hard to do the work in the right way. And so for me, the greatest level of influence in an institution is with the chief executive officer of the institution. So if I can report to a CEO, him or her can see firsthand and not be filtered with information from other people about what this work looks like and what it's going to take to actually close the gaps, turn the corner, and transform the institution. The second thing I will just frame up is not just to the CEO, but do you have the ability to present to the board? Because the board of an institution has a great responsibility of stewardship over everything that you do. And I was privileged enough that my institution, that I had both the opportunity to report to the CEO and present regularly at the board of trustees meetings around the progress that we were making. So I would lay that out for any CEO who's thinking about creating a role. They need to report to you. They need to be able to make some decisions, and they need to have access to the board. All right, I'm off my rant now. Now,
No,
let me
you
go
did
to the big thing. The big thing for you, and I think this is really important for us to highlight as we get towards the tail end of this conversation. What are some of the big wins that you've accomplished in working in your positions? I want to hear from all three of you about the successes, the things that you have been able to do that you feel like are some big wins to move things forward. And I'm going to start with Rochanda first. I'm going to hear from you from a community standpoint, the work that you're doing. How are you winning out there? Tell us what that looks like.
So I would say just a little bit of background in the work that we're doing with Community Solutions for Health Equity, funded by Robert Wood Johnson Foundation, is to address health disparities in DC through parent-led advocacy efforts. And so we started that work about 3 years ago. And I would say some of the big wins that we have accomplished, and the specific focus on families who have children, Black and Latino families who have children with disabilities and special healthcare needs that live in certain wards within DC, those most underserved communities. And one of the, I would say, of the big wins is one, the engagement of our parents, being able to, did I freeze?
No, we got
Oh,
you.
I'm sorry. Okay. The engagement of our parents. One of the first things we did, we conducted a community health needs assessment to our targeted group and community, got responses. We then brought on a number of parents reflective of the wards that we were targeting to train them and to dig deep into the feedback that we received from our community health needs assessment and to identify what are the priority areas that they thought needed to be addressed that will help increase health equity in DC. And so that has been a huge win with that process. That work continues through with my team here, through healing circles and conversations, because one of the things that we recognize and can be a barrier for individuals engaging in advocacy efforts is the trauma that they've experienced and the healing that the community needs to experience. And so the implementation of the healing circles have allowed us to bring in more parents who are invested in this work, who want to do this work, and who feel supported to be able to go out and advocate for both services for their children as well as improving health equity in DC.
Wow, fantastic work. How about you, Amy?
So I'd love to share just a couple wins focused on nursing here at Carle Health. When we first got started 3-ish years ago, I immediately recognized that we do not have a nursing workforce that demographically reflects the communities that we serve, particularly in terms of representation for Black and African American and also Hispanic nurses. So for 2 years, I was able to get small internal grants through a giving circle in our Center for Philanthropy to offer education awards to our team members in nursing adjacent roles like healthcare techs and phlebotomists who are Black or African American and pursuing a nursing degree. So we call it the Building Racial Diversity in Nursing program. And in the first 2 years, we distributed about $25,000 to, I think it's 22 team members over those 2 years. But last year, our Center for Philanthropy was able to dedicate their primary fundraising event for the year, which is a large golf outing, to the Building Racial Diversity in Nursing Fund. And the meeting I had right before this was to choose our recipients for this year because we have over $450,000 in that fund to support building racial diversity in our nursing workforce over the next several years. And I go back to that CEO commitment because that fund being chosen as the beneficiary of the Golf Open doesn't happen without his full endorsement and his working with our donors to help make that happen as well. A second nursing related focus is that we received a $20,000 grant from the American Nurses Association this year as part of their commission to Commission for Anti-Racism in Nursing. So we have a education series focused on nurses as change makers and how nurses can practice anti-racism in their day-to-day work at the bedside with patients. So that'll be kicking off this fall with some intentional learning and professional development opportunities for all of our nurse leaders. And I share those two together because it's really part of how we touch multiple pieces of our nursing workforce, both in demographic representation and diversity, but also building that focus on equitable care and inclusive, trusting relationships with our patients.
Fantastic wins. Thank you so much for sharing. Christina, how about you? Big wins.
I'm going to say, I feel like my work is made up of lots and lots of little wins that I lean into and roll all over in because they, these things build. And my most recent win, I will say, is we have finally gotten to the point where we have updated some of our standard dashboards that are routinely used by the nurses and folks on the floor. So I'm thinking about our patient experience dashboard. I'm thinking about our patient grievance dashboard. So we've been working hard to set the rules and understand, like, how are we going to look at this? How are we not? And finally, we have a prototype, and we're brought like a handful of really engaged users of this data to figure out how do we roll out the health equity piece of it all. It just feels like a win. Like we're having these conversations and people have so much engagement about like, what do we do with this information? It's one thing to have it, but how do we improve upon it? And I love the fact that it's not just me thinking about it, because I'm not a nurse on the floor. I'm not a nurse manager. I don't know how they're using this information. So to creating solutions collaboratively is what gets me up in the morning. And those are wins all over the place.
Christina, that is not any kind of small win. Do not.
I know. Well, I haven't solved racism, so that's when I'm waiting for that. So
Yeah.
That's
You can't,
that's a structural change in terms
Yeah.
of
it's a structural change.
but also a cultural change that people are
is.
leaning in and asking good questions.
I agree.
Don't minimize
Thank you
that.
for that. Thank you for that.
Thank you for sharing. And you can't downplay that work. I mean, that's incredible, incredible work. Okay, so I want to talk to the attendees here. I want all of our attendees to pay attention right now. We're going to do one final poll because the intersection is all about community, and we want your help in identifying and prioritizing future topics to discuss. So you have a poll on the screen that will give you some possible topics. I want you to rate them based upon your personal interest. For each topic, rate a scale of 1, meaning I'm not interested at all, or 4, extremely interested. And the topics are diversifying the healthcare workforce, building trust through community health workers, improving maternal health outcomes, coordinating multiple equity efforts across an organization, or using data to inform community health needs assessment. So if you have ideas for speakers or any additional topics, please email us at info@meetattheintersection.org. I'm going to repeat that email address. If you got ideas for speakers or additional topics to add, please email info@meetattheintersection.org.